Hi, everybody. I'm Dr. David Savin. Thank you for joining me for this lecture. A few disclosures. I am a consultant for a few companies. Nothing relevant to this talk. A little bit about me. I was born and raised in Los Angeles. I did undergrad in medical school at UCLA. Then moved on to Chicago. I did a residency at University of Illinois in Chicago. And then I did a fellowship at Rush University specializing in just shoulder and elbow surgery. While in Chicago, I was also one of the team physicians as part of my fellowship with the Chicago Bulls and Chicago White Sox. I've been at Desert Orthopedics for about 3.5 years. And since I've been out here, I've been only focusing on shoulder and elbow injuries. So let's talk about the shoulder. So the shoulder is a ball and socket joint. And I usually reference that as kind of being the golf ball on the golf tee. And the golf ball needs to be centered on the golf tee. And there's a lot of muscles that do that. And if I guess a better visualization if the golf ball and the golf tee was kind of turned sideways. The shoulder has a lot of ligaments and muscles that allow it to do the function that it does, because the shoulder has more motion than any joint in our body. And these muscles work together to allow your body to lift the arm up, rotate it, allow your arm to do function in space. Because of the high degree of motion the shoulder has, it's also very prone to injuries, dislocations, and tendon injuries. Well, what about the elbow? The elbow is also a very important joint in our body. So it allows elbow flexion and extension as well as rotation of the forearm. The elbow is more of a hinge, it's two joints in one. It's a hinge joint for the ulnar humeral joint, and it's also a pivot joint for the proximal radial ulnar joint. So the elbow allows rotation and bending. There are muscles in the elbow, and the easy way to think about the muscles of the elbow is that most of the muscles control the hand and elbow function. So the muscles on the inside of the elbow control the hand flexion, while the muscles on the outside of the elbow control elbow extension or wrist extension. There's also two main muscles that control elbow flexion and extension. Those are the biceps and brachialis, and the triceps muscle for the extension of the elbow. So let's talk about how can you prevent shoulder and elbow injuries. So number one, maintain adequate strength and flexibility. It's important to get a really good warm up when using these joints. Good posture, good form. Most injuries happen when you're lacking good form or overusing the joint, or when you're about to fatigue the muscles. That's when poor posture, poor form can lead to an injury. If necessary, the appropriate protective gear could help prevent an injury. For example, there's certain braces that help prevent dislocation. There's braces that protect your elbow if you have tennis elbow. And another key component is you should not push through the pain. So what are the type of injuries that we are looking at for the shoulder? So there's tendon injuries, there are dislocations, there are strains, there are overuse injuries, and there are fractures. I'm going to focus the lecture today on the most common tendon injuries, dislocations, strains, and kind of overuse injuries for the shoulder and elbow. We're not really going to talk much about fractures today. So I'm going to start with the shoulder. So an AC joint separation or AC joint sprain is a very common injury. This is a common injury that I see after a skateboarding or a bicycle accident, or even just falling over while playing tennis and landing directly on your shoulder. What happens is there is a ligament that attaches the clavicle to the rest of the shoulder, and those ligaments get injured. It's the only ligamentous attachment of the shoulder to the rest of the body. What you will notice on the top of the shoulder is somebody will have a little bit of a deformity on the top of the shoulder, right at the top. And you can see on this picture on the left side that there's a deformity on the top of the shoulder. And that's because they tore the ligaments on the top of the shoulder. And if you press on that, usually you could get that to push back down. So what do we do for this? Typically, it's conservative. A lot of people could rehab this without much difficulty and get a good functional shoulder. Rarely do you need to do surgery for this. And when we do surgery for this, it's typically a reconstruction to repair the ligaments. This is not a very common injury, but that it's not a very common injury that needs surgery, but it is a common injury that we see. How about a shoulder dislocation? This is the most common joint dislocation of our body. So the anterior dislocation is the most common, but the shoulder can pop out anywhere. Remember, it's a golf ball and the golf tee, and the muscle's job is to hold the golf ball and the golf tee. And if the ball falls off, it's hard for it to get back on the golf ball without being manipulated to reduce that shoulder. And what we see is the ball falls out of the socket, and there's usually a deformity of the shoulder once this happens. Some people are hyper flexible and can get the shoulder to pop out and pop in. Those are those double jointed people that we see every once in a while. And you can see right here, there's a socket and a ball, and the ball is no longer sitting in the socket. So what are the mechanisms? Usually it's a fall where the arm gets forced into a rotation. These are usually highly traumatic, but occasionally it can be a very low injury. I've seen people that roll over the bed wrong and dislocate the shoulders. Usually when that happens, it's associated with having some sort of a rotator cuff tear with the dislocation. So what are the signs? Usually there's a deformity. There's a corresponding trauma with this. You're unable to touch your hand to other shoulder because the arm is no longer able to rotate the way it was before. And there's usually associated pain. So what do we do for this? We need to get this put back in. You have to go to the emergency room. The shoulder needs to be manipulated in order to get the shoulder back into the joint. We usually immobilize these for about 1 or 2 weeks. And we limit strenuous activity to 4 to 6 weeks, and we try to rehab and get the muscle strong. Occasionally, there is a rotator cuff tear that needs to be repaired, and occasionally there are fractures associated with this, but most shoulder dislocations can be treated conservatively. There is a high incidence of recurrence after the first dislocation. And this is more common in younger athletes. There's a lot of ways for the shoulder to get put back in, but these are the type of injuries that we see movie stars in action movies where they push their shoulder into the wall to get it reduced. That usually does not work, so don't try that. Usually requires sedation and a doctor to pull on the joint to allow it to get the ball back into the socket. How about elbow dislocation? This is the second most common joint dislocation of a major joint. It's about 10 to 25% of elbow injuries, and usually there's an obvious deformity. Same kind of treatment. We have to get the elbow back into the joint. This usually happens by falling on an outstretched hand, using your hand to kind of control your fall, and you'll feel a pop, and the elbow usually is non-functional or difficult to move once that happens. So going to the ER to get this put back in place early will allow us to get the function back. And once you come see me, what we'll do is we'll start some early progressive motion and try to get your motion back while maintaining the stability of the elbow. This usually involves getting in a special brace that stabilizes the elbow while it's healing. How about biceps tendonitis and biceps ruptures? So the biceps tendon is a tendon that goes from the shoulder all the way down to the elbow. It can rupture at the top of the shoulder or the bottom of the elbow. Most common ruptures are from the shoulder, and those are typically benign. A lot of gentlemen could have this tendon rupture, and they'll notice some pain before the rupture, and the pain gets better after the rupture because the biceps tendon in the shoulder is not necessary, and we even do surgeries just to cut the tendon out of the shoulder. We'll talk about that a little bit further. So the biceps tendon is a tendon that goes through a groove into the shoulder. And this is typically seen as anterior shoulder pain, usually pain reaching to the backseat of the car or reaching across your body. This is probably one of the most common things that I see. Rarely it'll spontaneously rupture. And again, the biggest complaint is anterior shoulder pain as well as pain while trying to sleep. So how do you treat this? Non-steroidal anti-inflammatory medications. We can do steroid injections. And a key thing about steroid shot is the pain almost immediately goes away from the lidocaine in the shot. So if we give you a steroid shot and the pain does not completely go away, then we're concerned that the shot may not have been in the correct spot or it wasn't therapeutic enough. So we'd like to see that if we give you a cortisone shot, that the pain does disappear. We also could recommend rest and rehabilitation for this, and occasionally we'll do surgery for this if the pain does not go away despite conservative care. And this is kind of a good example of what the pathology that we're seeing is. So this is the biceps tendon in the shoulder, and it goes through a groove. And now you can see on this tendon, there's a lot of Can you hear me now?
Yes.
Okay, I think the video probably took away. Can you guys hear me now? Okay, so usually there's the bicep tendon goes through a groove, and this tendon is very inflamed, and this particular one has a nodule within the tendon that's going to cause a lot of discomfort as it travels through a groove. This is the reason why this pathology is very problematic. What we do for surgery on this one is we actually take the tendon out of the shoulder and we anchor it below the shoulder into the bone. This is, again, a very common surgery that I do for anterior shoulder pain for biceps tendonitis. And this is also a common thing that happens with a rotator cuff tear if you have rotator cuff pathology. Again, this is anterior shoulder pain. The recovery, you're in a month in a sling, you're protecting the repair for 3 months. Nothing that we can do to speed up the recovery of tendon healing. Tendons take about 3 months to heal no matter what we do. And this is highly successful in resolving the anterior shoulder pain. How about acromioclavicular arthritis? We talked about the AC joint separations earlier. This is pain on the same joint, but this is more related to arthritis in that joint. This is pain at the top of the shoulder. It's very common in weightlifters, and a lot of people have trouble sleeping on their affected side. The treatment for this, we'll try a steroid shot where we inject into the AC joint, and this pain usually goes away with the shot. Now, if it doesn't go away, what we'll do is we'll do an arthroscopic surgery to shave away the bone. And this is a very successful treatment for this pathology. But a lot of people do have arthritis of the AC joint without much pain. So we don't always recommend surgery for this unless the pain is debilitating. Recovery, it's often not an isolated procedure. If it is isolated, we can resume activity as tolerated because we're not repairing anything. It can combine with other surgeries. We usually let the more comprehensive surgery dictate how fast you recover this. How about the rotator cuff? Well, it's going to be a strain to a tear. It's usually lateral shoulder pain. A lot of people complain of night pain, and there's also a lot of weakness. The image on the right is an MRI, and we're looking at is this tendon at the top, which is black, and the white area, which is fluid. Usually this tendon goes all the way down to where that white arrow starts. And in this example of the MRI, the rotator cuff is completely torn. There are 4 tendons of the shoulder that are consisted of the rotator cuff. There's one in the front, one on the top, and 2 in the back. And usually the tendon on the top, which is supraspinatus, is the most likely one to be torn. Occasionally, you can have rotator cuff pain without a tear, and that's just considered rotator cuff tendonitis. And the reason why this happens is it could be a dynamic rotation of the arm with high velocity, such as overhead throwing. It could be an overuse injury. It could be overhead lifting. It could be poor posture or poor scapular control when lifting. Trauma, such as a dislocation, can cause this. And it usually involves people with a history of impingement or history of instability, meaning the shoulder has the tendon hit a bone as it's rotating. So what do we see? People have pain with muscle contraction. On exam, you can usually elicit a cuff. There's tenderness on the side of the shoulder. There's loss of strength or severe weakness. A complete tear will have significant pain and loss of function. Occasionally there's swelling. If there's an acute trauma, we may see some bruising. And one of the most telltale signs, again, is pain when sleeping. So having trouble sleeping. So here's some examples of what I talked about, the impingement syndrome. If you look at the image on the right, you can see with the arm at the side, there's space between the rotator cuff and the bone. But when you lift the arm up away from your body, kind of chicken wing, this bone could push the rotator cuff against the acromion or the bone at the top of the shoulder. So this is one of the more common things we call rotator cuff tendonitis or bursitis or impingement syndrome. Those are all pretty much the same thing. So what do we do for this? Again, RICE, so elevation, ICE, activity modification, rehabilitation. We modify the activity. We give you some exercises to strengthen the rotator cuff. We do an injection, and it's just like the other injection I told you about. If it's not diagnostic, meaning the pain does not go away, then there's something else going on. You should leave the office with significant reduction in the pain. That's how we know that the shot's in the right spot. And that's how we know that the area that we're thinking of as being your pathology is what we're treating. How about a rotator cuff tear? This could be a degenerative or traumatic. It's usually confirmed by MRI. And this is considered, we're evaluating this if there's persistent pain despite treatment or pain with sleeping. Now, I will give you a caveat that the older somebody is, the more likely they are to have a rotator cuff tear. About 90% of 80-year-olds or 90-year-olds have a rotator cuff tear without ever knowing. So the older you are, the more likely you are to have one. We treat the ones that have pain. So if you have a rotator cuff and have zero pain, we usually treat that conservatively. So we get an MRI to evaluate the rotator cuff tear. It confirms that diagnosis. It confirms that I can repair the tendon. It also confirms if there's any other pathology. But there is a difference in the quality of the MRI. So a good high quality MRI will really show us the pathology, where an open, poor quality MRI will be kind of like looking at a TV from the 1980s versus a new HD. Somebody for the MRI, it's strongly encouraging to get a good high quality MRI, which are usually the places that we send people to. How about other imaging options? We could do an ultrasound to look at the integrity of the tendon. When MRI is not a reasonable option, we'll consider that. We're also considering having this in-office arthroplasty where we can put a needle into the shoulder and look at the tendons without doing a surgery. It's a camera at the tip of the needle, and that'll allow us to look at the pathology within the shoulder. This is kind of new technology, and we're still trying to establish this in our practice. And I think it may be a good option for certain cases to have a good idea of what's going on in the shoulder. So what do these rotator cuff looks like? So they could be a small tear like this one on the left side where the tendon is supposed to be put down on the bone. And this is what I consider a small to medium rotator cuff tear, where the image on the right side, it's a very large rotator cuff tear where there is almost no tendon still attached to the humerus. And we can see a good idea of this on this video. I apologize, this video is not playing. But this is what a rotator cuff repair looks like. You can see that the repair is anchored back down to the bone. You can no longer see into the joint. I have a few other examples of what these look like. And again, another example of rotator cuff tear where there is a tendon that's detached from the bone. And what I do when I fix these is I'll put some anchors into the bone, and I will compress the tendon down to where it's supposed to be. This is a pretty standard rotator cuff repair for me, where I'll do usually a knotless fixation where there's no knots in the shoulder. We're just using multiple anchors to compress the tendon back down to the bone. But sometimes it's not repairable. Sometimes the tendons are so bad that we can no longer take your own tendon and repair it back down to the bone. So we have options for that. So number one, you can just clean it out and clean out the bad tissue. You could do a superior capsular reconstruction where I bring in a graft into the shoulder to augment the bad tissue quality and put a new superior constraint on the shoulder to give you the function that you need. Now, there's also a balloon spacer that should be FDA approved, hopefully this year, that kind of fills the space on top of the shoulder that keeps the humeral head depressed and allows you to use the remaining muscle of the shoulder more efficiently. Both the superior capsular reconstruction and in-space balloon have a similar function. Longevity-wise, this is all new technology. We're not really sure how long this will last, but we're seeing good data at about 5 years. But we don't have any super long-term data so far, but we're really hopeful this will be a good long-term solution. How about the reverse total shoulder arthroplasty? This is a shoulder replacement that we do when the rotator cuff is not repairable and you have inability to lift your arm. This shoulder replacement was FDA approved in 2004. And since its approval, it's now the most common surgery that we do for replacement of the shoulder because it works so well. It gives you pain relief, it gives you better function, and gives you strength in the setting of an irreparable rotator cuff tear and arthritis. And here's an example of a MRI where the tendon is so torn that the ball and the socket are no longer together. So now the ball is sitting higher than the socket. That's because the rotator cuff is no longer capable of holding it down. So what about the graft augmentation? Um, sometimes I'm unable to repair the tendon, or I'm able to repair it, but the tissue quality is pretty poor. So this is the example where I repaired the tendon, but I wanted to put a graft on top. And what I do is I anchor graft over the top of the repair to give us a little bit more tissue to allow that to heal. So that's another option that we have for these larger rotator cuff tears that don't have the best quality. So how about the superior capsular reconstruction? Again, this is where we anchor graft into the glenoid and on the bone. We're kind of creating a big cushion on top of the shoulder, and we allow the rotator cuff to heal to this graft. This is a fairly large surgery, and I'd probably consider this the largest arthroscopic surgery that we can do. But here's an example of one that I did recently where, sorry, hold on, let me open that up, where there was a big rotator cuff tear that I had no chance of repairing. I know that looks pretty chaotic, but this is looking from the same area. And as you can see, I can no longer see into the joint, and there's a graft that's now at the top of the shoulder. So this is a pretty cool technique to salvage the shoulder, and we call a soft tissue or joint preserving surgery for the shoulder in the setting of an irreparable rotator cuff tear. How about the balloon spacer? Again, this is a spacer put over the top of the shoulder. I'm hoping that this will be FDA approved within the next year, and the full use of this, we'll know more as we start doing more of it. But this is, again, a salvage operation that may give us a good functional use of the shoulder for a good amount of time. All of these are considered salvage operations because we can no longer repair the rotator cuff the way it was before. The reverse, we're reversing the ball in the socket. We're putting the ball where the socket is, and we're putting the socket where the ball is. This creates a fixed area for the shoulder to rotate on. And this is a surgery that we do when the rotator cuff is no longer functional. This works great, but I wouldn't choose to do this surgery for massive rotator cuff repair in somebody that's younger than 50 or even 55 because there's a high risk of complication. Once you, depending on activity level, tendon quality, arthritis, that's where we kind of choose which surgery is the right one for the person. And we don't really base it on age. We're basing it on clinical exam, the MRI findings, what they have done before and what their goals are, and what they're willing to do for the recovery. For example, the reverse has the easiest recovery, while the rotator repairs have a little bit harder recovery. And this is a discussion that we have in clinic when we're trying to make the decision that's right for you. So again, a big rotator cuff tear, which one's the right one? It's a decision that we're going to make together. How about shoulder arthritis? So what I usually say about shoulder arthritis is kind of like having a car with an old tire. If the tire holds air and you're still rolls and you can tolerate the ride, you can keep that tire going for as long as you want. Eventually, that tire is no longer going to work the way it did before. And that's when we have to do something for this tire. And that's going to be some sort of intervention. So what can we do? Well, let's talk about what causes. Usually it's age, overuse, trauma, instability. There's a genetic predisposition for arthritis. Usually you have pain, limited motion. You lose your ability to lift your arm up because the bone is no longer a smooth surface, and you lose your ability to lift your arm and rotate in space. You have difficulty with activities as well as sleep pain. So what do we do for this? Well, you could do pain management. You could do steroid injections. I usually say that steroid is kind of just putting more air in the tire and balancing it out, but you're still stuck with that same tire. You could do viscoelastic supplementation. There's some studies that say it works well for the hip and the knee. We've used it in the shoulder sometimes, and it seems to have a decent result, but these are not regrowing your cartilage. PRP and stem cell, these are both biologic options. There's good literature for PRP in the hip and the knee that say that they're probably better than steroid shots and the viscoelastic supplementation. But there's no good studies in the shoulder to really support that yet. But if we extrapolate the data, we think it may work. The downside is insurance does not pay for those yet. Stem cells, I'd caution you on. And if anybody says that stem cells going to regrow your cartilage or regrow your shoulder and make it normal, it's just not going to work that way. I think they do a really good job marketing stem cells, but the benefit of it, I think we're still trying to figure out the best role for stem cell in the shoulder. Shoulder replacements, again, we could do a standard shoulder replacement where I put a stem in, I place a socket or a little cushion in the shoulder. It's made out of a plastic piece called polyethylene glycol. And that works really well for primary arthritis. But if you have any significant shoulder rotator pathology, then we'll go ahead and do the reverse shoulder. Even if there is advanced age, if you're older than 75, it may lean towards the reverse because the recovery is easier. We don't depend on the rotator cuff anymore. And it's an excellent surgery. It's the most common shoulder replacement that we do. So what to expect after this? Well, now we're doing these almost always as the outpatient. You get an improvement in pain and function. You're in a sling for a month. For the reverse, we're doing exercises on your own, physician guided, doing band work and range of motion starting from the first week of surgery. A tendon takes about 3 months to heal. In order to do the shoulder replacement, I do have to cut one tendon to repair it. So we protect you for 3 months. Usually it takes about 4.5 months to get you back to playing golf. Overall, the satisfaction rate with a shoulder replacement is very high. Longevity-wise, we're seeing about 93 to 95% survival at about 10 years. And these are implants that have been redesigned multiple times since this data has come out. So we're hoping that the survival of this implant is even better than that. It's pretty equivalent to the survival of hip and knee arthroplasty or hip and knee replacements. Restrictions, I usually don't give any restrictions after a shoulder replacement. They resume sporting activity 4.5 to 6 months. I have people playing golf, tennis, going to the gym, playing pickleball, snow sports, and pretty much anything that somebody wants to do, they're doing. So how about, let's go back to the elbow now. So tennis elbow, one of the most common things that I see on the elbow is pain on the outside of the elbow. It's usually associated with racket sports, but you don't have to play tennis to get tennis elbow. Some people get tennis elbow while playing golf. And it's pain right at the lateral elbow. If you point to the lateral aspect of the elbow where you have that little bone protrusion, that's usually where it starts at, but it usually goes down the forearm, and it's pain with functional use of the hand. It's found to impact about 1 to 3% of the general population. Is very common, especially in the age 40 to 50 years old. Usually it's associated with overuse or doing too much. So what do you get? You get pain before, during, and after activity, pain on palpation, pain with gripping, squeezing, and pinching. A lot of men may notice that if they do a biceps curl with their palm facing forward, there's no pain. But if you do a hammer curl where your hand is sideways or upside down, then you have a lot of lateral elbow pain. What's the mechanism of injury? Overuse, repetitive force, lots of gripping. I see this a lot with racket sports, golf sports, moving, repetitive work use, hammer use. Anything that we're using your hand repetitively, it can cause tennis elbow. How about medial epicondylitis or golfer's elbow? They're the same thing. Tennis elbow is on the outside, golfer's elbow is on the inside of the elbow. Tennis elbow is with wrist extension, where golfer's elbow is with wrist flexion. And again, same thing, 30 to 50-year-olds, repetitive microtrauma. What's the mechanism? Usually it's throwing baseball, racket, or tennis sports, swimming, especially with a backstroke, hitting a golf ball. Usually it's overuse injuries. Or the clinical signs, pain on the inside of the arm, tenderness and palpation, usually pain with rotation. So for both medial and lateral epicondylitis, it's usually an overuse injury. You're by doing too much, you're not giving the tendon a chance to heal. The muscle starts fatiguing, so you get imbalance, you get more weakness, and it's kind of a repetitive cycle causing this injury. When we do surgery, what we see inside there is that it's not inflammatory. It's actually more of tissue that's just necrotic. It's called angiofibroblastic dysplasia, but I consider that as just a dense scar tissue of the outside the elbow. And if you look at it under a microscope, it's just disorganized collagen. So what's causing this? You usually consider this non-functional tissue. It's an inadequate repair where our body just cannot heal this area. I usually think that's happening because your body just does not have enough healing, or doesn't have the healing potential or good blood flow to the area to get this tendon to heal. So what do you do to treat this? Well, a lot of stuff works. So we We do activity modification, change the equipment, fix the equipment, change the way you stroke, stretching, exercising, brace, anti-inflammatory medications, heat and cold, and rest. We do a combination of pretty much everything. If you wait long enough, usually it'll go away if we did nothing, but most people don't want to do nothing and wait this out, because this could take months or sometimes even up to a year for this to resolve. Are there equipment issues? Is the shaft too stiff? Is the grip too small? Do we have to pad the grip more? Do we need to get more dampening from shock? Is there technique issues? Or is your swing poor? Do you need to go back to the trainer to learn how to properly swing and get the proper mechanics with your golf or tennis swing? Is the racket the right weight? Is it balanced well? Is it head size? Is the length good? Is there good flexibility on the arm, or is there good flexibility of the strings? Is it too taut? What's your grip like? Are you gripping too strong? Is the grip not cushioned enough? There's a lot of equipment issues that can cause this. So golf tips: don't hit off the mat, hit off the grass, proper weight shift, well padded and larger grips, flexible shafts, and try not to be risky or flicking the wrist with your swing. So treatment: don't play through the pain. Give it time, rest it, ice it. I actually love contrast therapy, where you go from heat directly to ice and go back and forth. Non-steroidal anti-inflammatory medications like Advil or ibuprofen, those tend to work pretty well. A stretch and therapy program, those are fantastic. Those work really well for this as well. And if you come to my clinic and I diagnose you with tennis elbow or golfer's elbow, I'll send you home with an exercise program. And occasionally, if you're not progressing, if you want to go to physical therapy or occupational therapy, I'll send you to therapy. What about topical creams? Voltaren gel, CBD, these all seem to help as well. That counterforce brace that you see in the picture on the left side, this is a brace that you put on your forearm, and it helps protect the tendon to allow you to do certain activities without causing further pain. So protect it, you ice and compress and elevate. You could do modalities, so heat, stimulation, ultrasound, extracorporeal shockwave therapy. What about medications? We talked about the painkillers. Cortisone, I want to caution against. I don't typically do cortisone for tennis elbow or golfer's elbow. There's now more and more evidence to show that this is a quick way to get you back on the field, but it's not going to give you any long-standing relief. So I tend to recommend against cortisone because in the long term, it tends to be worse than conservative care without cortisone shots. What about platelet-rich plasma? This is your own blood concentrating the healing factors and injecting this into the tendon. As I told you earlier, this is a scar. This is disorganized tissue that's not healing because your body doesn't have the healing potential in that area sometimes. PRP works great for this. There's actually more and more evidence that support PRP. Again, I'll give you a stretching program and an exercise program to help rehab this. The counterforce brace controls the internally generated muscle force of the elbow to allow you to do certain activities without pain and without causing further damage. Injections, caution you against steroid. There is more and more evidence that steroid has significant negative effects on the tendon cells, which reduce cell viability and cause them not to grow and heal. Again, worse clinical outcomes after a year with steroid injection. So I tend not to do cortisone shots. So you have to think about the comfort versus the cure. A steroid shot will get you back on the field really quickly, but you may not last on the field for very long because it's not going to cure the problem. So pain relief and comfort techniques typically do not specifically induce a biologic or physiologic tissue response. What we want to do is get the tendon to heal. So if not steroid, then what do we use? We talked about the platelet-rich plasma. It's where we take your own blood, concentrate the healing factors, and we take almost 100 cc's of blood and we get about 4 cc's of PRP. So we get a very concentrated platelet product that has a very robust healing potential. And if you look at clinical studies, it favors PRP over anything else that we do. So it seems to be the best intervention that we have that's not surgery. Well, surgery is still an option, but sometimes just cutting it will make the situation a lot worse. But if we're going to do something, we have to do it in the right patient. We have to do it for the right circumstances. We have to fail conservative care. And I usually wait about 4 to 6 months before I recommend a surgery. We try everything possible before we proceed with surgery. So what are the goals of surgery? We have to cut out the bad stuff and we have to leave the good stuff. We don't release the tendon. We try to address additional problems at the same time. So if there's concomitant pathology like a ligament injury or a nerve issue, we'll take care of everything at the same surgery. When we get inside there, we see this diseased tendon. And what we do is we clean it out, we drill the bone, and we put an anchor in there and we repair it. So we repair the tendon back down to its normal tissue, cutting out the bad tendon. And this works really nicely for this. And this can be done through a small open incision or arthroscopic. Depending on what the pathology looks like, we'll discuss what we're going to do for the surgery. Rehabilitation, usually we get your functional use of your arm after 1 week. Usually after a month, most people feel a lot better than they did before surgery. Easy sports at 4 to 6 weeks and play to win 4 to 6 months. So there is a recovery, but we get you back pretty quickly. Results of surgery, 97% significant relief, 90% return to prior level of sports. So overall, it's a very successful surgery for somebody that's failed conservative care. So final thoughts on epicondylitis: don't push through the pain. Rehab and rest it is the first line of treatment. There's limited or very little use for cortisone injections of the elbow for elbow. Consider biologic injections. Be patient. It takes time for this recovery. And if everything else does not work, we recommend surgery. So what about biceps tendon tears? We talked about the biceps tendon in the shoulder, but you can also rupture the bicep tendon at the elbow. And this is usually in males over females. It's not very common, but it's one of the more common acute injuries of the elbow that we see. And what happens is usually you're flexing or lifting something heavy. What I see in the general population is somebody's moving a fridge or a couch with somebody else, and the other person doesn't hold it evenly, and you get an uneven load on your arm, and then you feel a pop and get immediate pain and weakness. Usually affects the dominant extremity, but I've seen it in bilateral arms or a non-dominant extremity occasionally. And what we see is the muscle balls up because the tendon pulls up the arm, and you get a ball of muscle causing what we call a Popeye deformity. Again, another example of a Popeye deformity. Usually we get an MRI to confirm it, but I usually know by a clinical exam that this tendon is torn. And we usually move pretty quick on this because we usually don't treat this without surgery. This tendon, in order to have functional use of the arm, as the bicep tendon is the main muscle that allows you to rotate your forearm, such as opening doors. Without that tendon, you tend to have persistent pain and dysfunction. So I usually recommend fixing this. And what I do is I actually anchor it into the bone to repair the tendon back down to its footprint. Just like any other tendon, it takes 3 months for this tendon to heal. But we try to fix this within 1 or 2 weeks, as the longer you wait, the harder it is to fix this tendon. Rehab is slow and steady. We get your motion back in 6 weeks. We rehab you more aggressively for the next 6 to 12 weeks, but we don't start strengthening until 12 weeks. It takes time for these tendons to heal. Just like the biceps, we can also rupture the triceps of the back of the arm. I've seen this with people pushing out of their chair, pushing away, doing a push-up, doing overhead triceps extensions. Again, this happens in males, 30 to 50-year-olds. We see some bodybuilders, athletes, some sort of heavy load that was not expected. This is more common in people that are on steroids, systemic illness, or if they've recently taken certain antibiotics, those could increase the chances of a tendon injury. So you usually feel a sudden pop. There's weakness with elbow extension. It's funny that with these 2 tendon injuries, the pain usually is not that bad, but you do feel a big defect, that there's something missing in the back of the arm. And occasionally we'll see a small bone piece that came with the tendon to suggest that that tendon's been torn. We repair this with sutures and anchors to repair it back down to where it's supposed to be. And usually the recovery is really good. It's same as the biceps. It's slow for the first 6 weeks, get your motion back. The next 6 weeks, we'll do a little bit more aggressive motion, especially rehabbing the shoulder, but we don't start strengthening the triceps until 12 weeks. Olecranon bursitis. I see this a lot out here. This is a fluid pocket on the back of the elbow. It's usually aseptic, meaning it's just traumatic, where you just fill it with fluid. Rarely do we see this as an infection. Usually, if there's an infection, there's a cut or an abrasion or some sort of traumatic wound to the back of the elbow, maybe an insect bite. But usually, this is not infectious. If it doesn't look red, if it's not very painful, then it's considered an aseptic olecranon bursitis. There's a difference in infection. If it's more red, if it's more diffuse up and down the arm, if there's erythema, draining, if there is fevers, then we consider that to be a septic olecranon bursitis. But if it just looks like fluid, it's not really red, it just looks like a golf ball on the back of the elbow, that's usually a benign pathology. That's not an infection. So what do we do for this? We use cold, we compress it full time with a compression sleeve for 4 weeks, some topical Voltaren gel. I urge you not to have somebody put a needle in this. A lot of doctors like putting a needle to take the fluid out. The skin is very thin on the back of the elbow, and you're predisposed to get an infection back there. So having a needle in the back of the elbow could increase your chances of developing an infection, something that was not previously infected. I have one gentleman that had an aspiration in Chicago, and when he came over here, he was infected. It took 6 surgeries to resolve this infection. So I usually don't aspirate this. When I do aspirate, I use a specific technique that reduces the chance of that complication. So if it's recurrent, then I may take a fluid sample out to make sure that there is no evidence of infection. And if it is infectious, we will try antibiotics. If that does not respond, we'll do surgery for this.